Why don't we get started, Neil? So welcome everyone to Citywide Sports Medicine Rounds. My name is Mark Leung. I'm the program director for U of T Primary Care Sports Medicine, and I'll be moderating today. Just a reminder that these rounds are recorded. I will be moderating, and so I'll be keeping an eye on the chat for our speaker, Dr. Neil Dilworth, who is he's actually the chair of our competence committee in the primary care sport and exercise medicine program here at U of T. He's also an assistant professor in the Department of Family and Community Medicine. And he's the creator of the open source sportmedschool.com educational resource. He's also a consultant for the Toronto Football Club and an emergency physician for Halton Healthcare. And Dr. Dilworth is going to share with us today on the topic of AI in sports medicine, its potential uses, benefits, and drawbacks. And just before Dr. Dilworth starts, just a reminder to do the survey at the end for continuing education credits, both at Royal College as well as the College of Family and Community Medicine's main pro credits. So finish your survey at the end. And without further ado, I'll pass it on to Dr. Dilworth.
Thank you very much, Mark, and David for having me today. And we're going to get started. If anybody has any questions along the way, like Mark said, Mark will be monitoring. I'll also be keeping an eye. If you can't hear me or there's a problem with seeing the slides, also please just let us know in the chat group there. So let's get started. For those of us looking forward in sports medicine, this is a fairly important topic. If you haven't heard of artificial intelligence at this point, I'm not sure where you've been, but it's really come to the forefront in the last year and a half, and it's starting to encroach on all aspects of life. I've got to start with some disclosures. I am the owner and director of a medical device company unrelated to this talk. And that's last you'll hear about that. And AI was used in this presentation. So image generation, slide design, and also for demonstration purposes. These are the objectives today. The main take home is that I really hope you guys can understand that one, these are tools that use AI and how they're being used. To know how these tools can be used, perhaps improve your practice flow from a sports medicine perspective, and to understand that these are available to everyone, so including your patients. And there's also significant risks and concerns and limitations to AI. And I think that's also very important to understand prior to using these tools, but also while you may be observing other people using these tools. And then finally, to know that the importance of human supervision when using these tools. These are not replacements for humans. So AI, artificial intelligence, what is it? So there's many features of artificial intelligence that have already been in our lives prior to the arrival of a ChatGPT or a Microsoft Copilot or whatever you want to consider for your generative AI purposes. If we think of the basic search engine from a Google perspective, even banking perspective, as you can see here, I've got an image of a check. These are fairly complex programs that involve a combination of not just using large language models, but they also are embedded with these what are called neural networks, and carry out these fairly complex tasks that we use on a daily basis and we don't think twice about. And part of today's talk is that we're going to start thinking twice about how these kind of function. When we take a look at a search engine, for example, that's based on predicting what your next word might be based on scrubbing the internet of billions of words of text and then predicting what the next thing you might type. That's a language model. These are called foundation models. There are visual models. Certain examples of like a vision model would be where you can show an AI tool an image and it can essentially then give you a text output. Your Hey Siris and your Alexas, those are examples that involve audio-based or audio-based foundation models. And these are all based on essentially applying mathematics to the language input that or the initial input that you're putting into the AI. So they're fairly complex. We talk about um, different parts of AI. The interesting thing is that when you put an input in, such as like a text word, so just for the example, the Google search engine, that gets put into the system. The word is assigned a number, and there's algorithms for giving these words numbers. They're called vectors, and then it goes through a number of fields that involve a number of different nodes, and each one of these decision points are called parameters. We don't understand, it's not fully understood in a number of these processes how the decisions being made in between the parameters. And I think that's an important piece to understand. So that's why one of the reasons why sometimes you will input the same command and get different outputs out at the back. It's a bit like playing Plinko, that Price is Right game where you drop a disc from the top and it kind of bounces back and forth and can land at a different endpoint each time. So who is using AI? Well, number one, your patients are. No different from their ability to ask a question in their 15 to 30-minute consult, or perhaps it's a 3 to 5-minute consultation with you. They can also be asking one of their generative AI apps the exact same questions. So I put an example here of putting in an input to a generative AI product called a Gemini by Alphabet. And what graft options do I have for my ACL reconstruction? And in fact, it'll spit out a generic, this was at a request for a table, and it spit out this table here. There's a number of available generative AI apps. These are, once again, based on large language models trained on hundreds of billions of words. So where do they get this data from? They essentially take it from all over the internet, Wikipedia. They go on to your social media sites. So, this is the other thing is like, there's only a limited amount of data. And these models require large amounts to be able to function the way they are. And so if the current data that we have is only representative of a certain portion of the population, or it's weighted by a smaller portion of content developers compared to the rest of the population, you can see how that may affect the output of these large language models. So the other group we obviously want to know today is who's using AI specifically in sports medicine. So this is a quick poll or survey we sent out to 60 sports medicine physicians, sports and exercise medicine physicians, orthopedic surgeons, physiatrists, and 31 respondents. About half used AI and half didn't use AI. About 1/5 were using it to aid them in making presentations, as well as 1/5 were using AI Scribe, which we'll go over today, and 1/5 were using it for clinical queries. There are a few people responded about imaging analysis. When I asked specifically about that, correspondents were saying that they were actually feeding the report in to the generative AI to get a better understanding of what that report meant. So there's another example of using the generative AI as a conversational tool to get a better understanding of what the next steps might be. At this point, nobody's using it for research. Maybe, and hopefully that might change after today's talk. And nobody's appearing to use it for clinic management, and that might also change after today's talk. So right here, I've got an example. This is a product by Meta Llama 3.2, where, just to give you an example, this is freely available. If somebody has this app on their phone, WhatsApp, I've just put in a number of different scenarios to give an example. Flexion type low back pain. Do I need an MRI? And the next one was playing hockey, hit my head. I've got the following symptoms. Do I have a concussion? ACL graft question again. And you can see in the ACL graft question this time, they've actually gone through the actual autograft possibilities for you. So in terms of your patellar bone and your hamstring and quadricep tendon grafts. And then the final one was a rotator cuff injury going over for 3 months. And you can see that when you ask the generative AI, you feed it into these large language models, it spits out not just an answer, but actually spits out an empathetic message to start off. Sorry to hear that you're experiencing back pain. Sorry to hear that you got hit in the head while playing hockey. So maybe in some respects, it might even be a step above our own care from that perspective. But it gives reasonable answers on the output. What I will comment on is that this is my input into the large language model. So I'm putting in almost a summary of a sample patient symptom complaint. However, a patient might not use the same words, and therefore they might get a different output altogether. And this is where the human supervision is very important, and perhaps even I would argue a physician supervision or at least advisory would be helpful. In terms of sports medicine clinic, there's a few options that I'll review today that could help with both productivity, but also flow. The first one is chatbots. The second one is an AI scribe. As you saw from the survey, about 20% of the GTA sports medicine physicians are using an AI scribe at this point. Once again, that may change after today's talk or may not. And then the final one are clinical queries. Just like a patient can ask questions into the generative AI, you saw that about 20% of sports medicine physicians are querying these generative AI on things that they may not understand fully, such as the radiology reports. So chatbots are a very useful tool that can essentially free up administrative tasks. So this is a conversational tool that can take place in a text format that you can have on your clinic or hospital website, and it allows a patient to interact with the app, which can be trained specifically to your clinic needs, and it can allow them to get information such as, like, whereabouts the clinic or the hospital is, where what they have to do to prepare for the appointment. But then it can also essentially extract data from the patient and ask about patient demographic details, phone number, OHIP, and such, and date of birth, so that that can then prepare the clinic for the patient's arrival ahead of time. So these are, these can be significant time savers that can be embedded up to take some of the burden off of the administrative tasking that can occur on a daily basis. AI scribe. So currently, this is the three options, is that we either document directly into our electronic medical record by typing ourselves, we can dictate, or now we can use an AI scribe. And these scribes, there's a number of different products available. They can significantly reduce the administrative burden of the documentation. Some reports anywhere from 20% up to 70% of charting time can be reduced. And some of these can be integrated directly into your electronic medical record, so you don't have to worry about even copying and pasting. There's the possibility of having translation embedded. A few of them have up to 60 languages. Um, I have to say, it's hard to know what the accuracy of the translation is. Having done a multilingual translation project back in 2019, there was several issues with using some of the major tech translations in that it's decent for kind of colloquial language, but however, for sports medicine specific or medicine specific language, there are nuances that you really want to check with a native speaker. Um, these essentially, you can have them on your phone, and you go into the room, you consent the patient, and it'll record the conversation, and then it'll spit out a note afterwards, and I'm going to show that in a second. So the other thing that patients report is an improved interaction. So the physician's not, looking at their computer or their tablet, they're not doing other things. They're looking directly at me, and it's been one of the common reported improvements that patients talk about. This is an example of an encounter. Now, I consented this patient prior to turning on the app. This was specifically for this talk. And you can see that it records the conversation, including some of your linguistic nuances that you may use. You'll see throughout this paragraph, there's a lot of okay, yeah, okay, which is apparently what I do to keep a patient moving along while I'm in the emergency department. But it will take this paragraphed dialogue, and then it'll essentially identify a number of different words and phrases, and it will extract that from the conversation. It will ignore things that are not related. So if we were talking about, for example, our dogs and how often we go for the walks and what our vet bills are, that does not go into the note. And then it spits out at the end a nice, concise medical consultation note. Okay. Here's the important thing here. So just like if you're dictating and you should be checking your dictation, these notes need human supervision. Okay. Um, these are, these are instantaneous. The accuracy is fairly similar to dictation. I've been using AI Scribe now for about a month, and it's fairly similar. And you can format the notes to whatever your style that you want to use in your practice. It's hands off. You can focus directly on the patient, and it definitely saves time on notation. Okay. Couple things though. It may leave out some important things that you may have asked in detail. And because you're not doing the notation or dictation, you may not be actively thinking of that having been missed in the note. It can make obviously errors in the transcription. There's privacy concerns, so you want to make sure that you're not discussing any personal information in the conversation, because it's not just that it may go up in the note. Some of these will get drawn up into the language models, and this is something we'll talk about later on. The other question is, where is that data being stored and how secure is that? So you want to ensure that if you're using an AI product in Canada, that they're storing it in Canada, so that it's privy to Canadian laws and regulations. And then the final thing, and this is really the bigger piece one of the bigger pieces for me, because when you come out of the room, or you finish at the end of the day and you're finishing your notes, or you're doing your dictations, these are reflection points, and you don't really get the same reflection time using these products. The second piece is, because it's automated, some of the things that you think to do on a regular basis may start to wane over time. And the concern, and this is one of the concerns with AI products with the automation, is that, are we going to perform less efficiently, or sorry, not less efficiently, but to a lesser degree than we would have if we were doing these things ourselves, such as the history process and the physical examination process. Just things to think about. These are just a number of the AI scribe products. They range anywhere from you have free options with a number of them up to roughly $100 a month. These slides will be up afterwards, so don't worry about having to take these things down. And we'll probably have a page up on the Sport Med School as well. Once again, it's free access. So clinical queries. We talked about, feeding in a radiology report into a generative AI. I'm going to give actually another example of the power of some of these tools. This is a case here. We've got a 21-year-old female varsity runner. She's always tired for the last like 2 to 3 months. She weighs 55 kilograms. She's been amenorrheic for the last 5 years while competitive running. Her hemoglobin is 116. And I'm going to put this out to the crowd. Who wants to guess her iron deficit? Anybody? Is anybody feeding this into their generative AI app at the moment? So this is what you can do. And so on the left of the screen, you will see this is put into Copilot. You can see where I asked it to generate images beforehand for that particular slide. And it's taking the information and it's spitting out and it's saying her iron deficit and how much iron she's going to require is, I think it's about, this one says about 800. There we go, 816 milligrams. However, when I put it through the Llama AI, generative AI, it comes out with a dose of 549 milligrams. When I do it myself and I put it through the MedCalc, the Ganzoni equation, it comes out to 553 milligrams. Now, obviously, that's closer to the Llama. My point is not to say that one of these generative AI apps is better than the other. The point here is just that, one, you want to understand that the process that the tool is taking to come to that decision point. And both these actually show the process that they got to that decision point. But you also really want to know how that process works yourself so that you can check it. And so I wouldn't go and leave your up-to-date aside or and cancel your other medical subscriptions. I think this is something whereby it's very important, especially as professionals, that we are keeping ourselves up to date and that we are checking these answers as patients depend on them. Diagnostics. So this is really one of the pieces that really highlights both the phenomenal potential of AI, but also the significant limitations. So first off, we're going to talk about radiographical diagnosis. There's been a lot of talk about, oh, radiology, that's something we could potentially replace with AI. That's highly unlikely to ever happen, and we'll go into detail why. However, as we will see, it can significantly improve the workload process, and we're going to see why that is for radiological diagnosis because it highlights how AI works. So, for the purposes of the training models, when you're training these AI systems, they require, a lot of data that is well defined. And what better than essentially a series of pictures with small changes in between? And I've just on this slide, you can see an example of a neural network. And you can see how complex these neural networks are. This is kind of a basic illustration of it. There are several layers at each step that are narrowed down to an individual icon on this diagram. But essentially, if you have a large image picture of your screen, it may break it down into, let's say for argument's sakes, 1,000 pixels. Then each one of those pixels will go through a node and then a filter or a series of parameters until it gets to the endpoint to an output. And then as it's analyzed all those pixels, those 1,000 pixels, and gone through all those processes, you can see that at each step of the way, it can have, uh, anywhere from, a few decision points that can change a direction to maybe hundreds of thousands to hundreds of millions. These are very complex processes. And then at the end, it spits out a probability. So for example, if this was a shoulder X-ray, it could give you a probability of, 99% or 99.9% this is a shoulder dislocation. So from a radiology perspective, we can feed in whatever images, series of images we want, and you can essentially train it to take a look at things. You can, if we're talking about neurology, you can talk about, measure multiple sclerotic lesions, and it can both count the number of lesions and measure them far quicker than a radiologist can, because of the way the models are set up. So it can save time. Um, and then you can also speed up the way the images are acquired. And we're going to go into that in a second. Now, if we contrast the radiology diagnosis to a clinical diagnosis, then we start to see where an issue comes in. So if I feed into a health chatbot, these are these AI tools. I don't know if any of you seen them. Some of your patients may have used these, where you feed in your medical complaint and it spits out a diagnosis. Now, for some of the emergency complaints, it works phenomenally. From a sports and exercise medicine perspective, it doesn't work as well. And the example I've seen, and this is when I first tested these back in 2019 to today, it still has the same problem. And so I put in, I've had right groin pain for 3 months, wakes me sleep, worse with stairs. What's the diagnosis? And we're going to go into what happens with that. But when you have less defined data that has a greater heterogeneity and there is multiple nuances to it, the AI tends to do much more poorly than if you were to have more consistent data. So going back to the radiology, yes, it can aid in the diagnosis, which we'll see in a second. What's fascinating is when you send somebody through an MRI, it takes time to come up with these images. And what the MRI can do, or what the AI can do, software can do for your existing MRI, is that it can actually increase that acquisition time. So you can actually do more tests in a day and see more patients. So uh, I was talking with one of our radiologists down at Mount Sinai, and they're now using Deep Resolve, which is a Siemens product. And it says here on the website that it can decrease the knee MRI to 2 minutes, but he's saying it's gone from 22 minutes down to 6 minutes. Now that's significant, right? You can do more than 3 MRIs in the same amount of time that it took you to do the one MRI prior to using that tool. Like I said, it can also aid in the quality image. It can improve the resolution quicker. And then from a diagnosis perspective, reaching out to one of my colleagues in Ireland, they use a product called Gleamer. This is integrated right into their PACS system. And it has a number of tools that will essentially allow and aid the diagnostic component. So once again, if we're looking at these images or a radiologist looking at these images, we may be looking at, 10 pixels or 20 pixels at a time. Whereas the AI is looking at every single pixel of every single image and therefore detecting these patterns at a far quicker rate than we may. You can see the X-ray here on the left. It's showing if you take a look at it long enough, you'll see that there's a lateral tibial plateau fracture. And then you can see on the lateral X-ray on the right that there is a lipohemarthrosis just above the patella. So you can see both an effusion and you can see a large fusion and a fracture. And then that gets highlighted by the yellow box when you turn on the AI tool. What is the accuracy of AI compared to radiologists detecting specific knee pathologies, such as meniscal tears, ligament injuries, or cartilage defects on MRI scans? So what did we do? We took a look at 100 different papers, scanned through, got 10 that met the inclusion criteria. Um, and about half the studies, it showed that AI improved or outperformed human clinicians. Three mixed results, and
Sorry,
one
Mike, you're
study.
losing.
Hello? Somebody have a question? And one study found no significant difference between the AI and human performance. Now, this is actually another AI tool, which we're going to get into in a second. This is a research tool where it helped develop the question that I want to ask, and then it went through and did a systematic review. What's interesting is in the 10 studies, the studies ranged in size from 100 scans used in the study, and all the way up to 23,000. And what's interesting was there was no weighting made in the decision of the analysis. So you can only imagine a study that looks at 23,000 scans where they found significant improvement in AI accuracy compared to clinicians, was not weighted any more than the study where there was 100 scans used. What's interesting is one of the themes in this as well was that as they retested the AI, it continued to improve on the accuracy. So as they continued to feed more scans in, they got better results. Now, going back to the comparison to our clinical diagnosis, this is where I put in the right groin pain query into an AI health chatbot. It actually asked me if I was having a decreased range of motion in my hip joint and if that caused pain, both to which I said yes. And this is what it spat out as the differential for my condition. So nothing about hip OA or femoral acetabular impingement. These are all back related. Now, why is that? Well, part of this is a linguistic issue and how we assign vectors to each word for the AI system to be able to navigate. And when we talk about the term groin, there's a wide variation in the understanding in language what that means. So it can mean anything from midline genitalia to adductor muscles, to up to the abdomen, and all the way out to your greater trochanter. So this is something where, and also anterior and posterior. This is something whereby the AI chatbots really struggle with defining, even with asking multiple questions. And the second piece is that there's a lesser literature amount on sports medicine topics. So, the amount and the volume of information is weighted towards back compared to, hip pathologies. And this is kind of one of the things you want to think about in terms of when we talk about bias, and we'll be talking about this later. The AI tools are biased towards what they see more of. And sometimes that doesn't make sense. And this is a perfect example where a clinician wouldn't diagnose somebody with these based on the presentation symptoms that I put into the system. So when AI performs badly, well, so once again, it's highly dependent on large amounts of data, reliable data. If we have poor data or lesser amounts of data, it's not going to work as well. And an example I like to give is if you're trying to develop an AI system on detecting smells, it would be extremely difficult because, for example, a coffee or garlic will smell differently to different people. Then different people will also use different descriptions of that same smell. And then culturally, there are also different cultural variations within that smell perspective. So there's something where the data is going to be so heterogeneous that it's going to have a significant difficulty delineating out how to come to a singular conclusion. The other thing with what happens with AI and limited data is that you start to notice performance decline because when you have large amounts of reliable data, that's when it really recognizes these fine minutia and these patterns and be able to, for example, with the X-rays or MRIs, to see fractures that can't be seen by the human eye. But when there's lesser amount of data, it takes the smaller amount of data, and it will then essentially it may recognize a pattern, but that pattern may not be generalizable the same way as if you had a larger amount of data. And it's something called overfitting. What the AI system will try and do with a smaller amount of data is it'll try and take that one rule that they've figured out from the small data and apply it everywhere else. And that's not a very good solution, obviously. And just understanding that and not thinking that these AI tools are wonderful in every which direction is a very important piece to go forward. Research. So nobody in our group that I surveyed, I don't know if anybody's listening, uses for research. But there are a number of AI tools now that are available. These could help develop your research questions, as we saw with the AI question, the AI in diagnostics question I asked about knee MRIs. I initially asked about, I think I said I put into the AI tool, excuse me, AI versus radiology accuracy and knee MRI, and then it essentially reformulated the question to include outcomes. It'll summarize information, so whether you want to put a PDF in or text or web-based articles. It'll organize your citations and insert references. So these are very, very helpful tools, significantly reducing administrative tasks in research. And the other thing from a academic perspective is that there are tools in these that can check papers or submissions for the AI usage in the text. And, you know, I'll make the point here. One of the concerns I have with the incoming AI boom is that it's going to significantly increase the content being put forward. Now, how much of this is new content versus AI created on existing content? This is going to be difficult to delineate in terms of original ideas versus not so original ideas. And therefore, that's going to get fed back into future language models as well. And once again, we may essentially further weight the system. So in terms of research question formulation, I'll just go through the details here. So you can ask, for example, this is a question I put in about developing a systematic review on the use of PRP in ulnar collateral ligament tears. And so the system I was using for this one is recommends, well, why don't we use the PICO format? I said, great. And then it gives broad to very specific questions along with reasoning as to why it's recommending those to you. And then we came to the formulation of what is the evidence from randomized control trials regarding the effectiveness of PRP injection compared to placebo or conservative management for the treatment of UCL tears in pain reduction, functional improvement, and healing rates. So we get the comparative, we get the outcomes in relation to the intervention here. These are the tools here. This is an example of consensus. This is an AI research tool by Microsoft. Now, just as we can use these, a patient can use these and ask a question. It can refine the question for the patient, and then it'll spit out a consensus based on if you're not paying for a subscription, 5 articles, if you're paying for a subscription up to 10 articles or more. I put in here, this is the same question I had put previously about the diagnostic accuracy of AI for knee MRI. And it's actually trained to give you kind of a pro and con. So like and that's why they call it consensus, is that it'll give you, what the positives of a certain treatment are, but what the potential side effects or drawbacks of a potential treatment are when it spits out the answer. This is an example of SciSpace. This is another tool. It'll also obviously assist with question formulation, but the reason I put this up here is just to give you an idea. You can feed in a PDF, and then you can have a chat, so you can have a generative AI function within that, and you can ask the AI tool to specific questions about the PDF. So here's a differential guide that Dr. Franchella and myself, along with a number of our colleagues, I see Dr. Rindlisbacher on and Dr. Leong here, created back in 2020, 2021. And it's a differential guide on from head to toe on sports medicine diagnoses. Excuse me. And I just asked it, what is the differential diagnosis for ankle conditions? So search through the document, and then it summarized what the differentials were. The limitations now, this is another reason why we want to be understanding the limitations. These look very impressive at the outset. But when we go to the next slide, you'll see, excuse me, that they have limited databases. So now there is a workaround, but you can see that only one of them here, the illicit, integrates with PubMed. The other ones are using various databases, so they might be with certain publishers like Elsevier or Sage, and they're going through, and a lot of them are dependent on open access resources. Otherwise, they're pulling out abstracts. But you can do a workaround. You can use Google Scholar or do your search through PubMed and then download the PDFs and then feed them back directly into these tools. You can see that most of these have a free option, and then there's a subscription option. They're usually around $12, $13 a month. So you can see that these are fairly powerful tools. They also have some limitations and some concerns around them. So when are we going to start talking about AI regulation and specifically with respect to how it pertains to sports medicine? And so from this, we're drawing from other fields. When you talk about the journals, what they're recommending. So, one of the questions comes up, well, if I'm writing an article and I'm using a generative AI tool, do I put, ChatGPT 4 as one of the co-authors? And the answer is no. And hopefully you're not using it that significantly that you want to put them down as a co-author. Each journal will have an outline as to what their recommendations are AI. They've kind of, for the most part, recognized that this is a commonly used tool. They really want it focused more in on like the language use, like in terms of checking for grammar, perhaps rephrasing it so it sounds more scientific and such. It's not to be used for original research, i.e. like feeding small amount into the AI and then spitting out results. We're not trying to make things up. That's very, very important to take home. You do want to, just as I had mentioned before in terms of the disclosure, if you're using it in a presentation or obviously in the writing of a paper, you want to disclose how you've used it and what you've used it for. And it's not to be used for the conclusion, which this is another interesting piece. And we'll see at the end that these tools, even as I speak, there's an option on Zoom to summarize this talk. You really want to be doing that yourself from an author perspective. And the other thing is that we're not supposed to be using these as peer reviewers. So if you're a reviewer of articles, whether it's for CJSM or British Journal of Sports Medicine or one of the orthopedic papers, you're not supposed to be using these to feed the paper in, because what happens is if you feed somebody's research in, it's not published yet, that gets drawn up into the data for these large language models. So again, another privacy concern. So another important thing to keep in mind. And then obviously from a clinical use perspective, where we're talking about AI scribes and such, we want to essentially make sure that the data is secure. We're not taking any private data. And be aware of the things like that can occur over time, such as data corruption. Where are we for time-wise? Does anybody have any questions at this point? Mark, is there anything on the chat group?
Chat right now, Neil.
Perfect. Okay. If there is, please don't hesitate to ask. The limitations and cause for concern, I've broken them up into. Excellent question. Do you find much pushback from patients with using AI scribes? So No, I haven't. So I think this is there's probably a cultural component to this as well. But I will typically go in and I will ask the patient for consent. And I say, if you don't want to do this, we don't have to do this. And so, no, that's fine. But what's interesting is then, especially from an emerging perspective where you're asking personal questions, there's been a couple times where I've noticed hesitance because it's being recorded. So uh, that's definitely something you want to keep in mind that patients who are a little bit more private, and I don't want to say paranoid, but they may not want to share the same amount of information given some of the concerns I just described. The other question there is, are there any tips for recoding, or I guess it's recording physical exam? Mind you, then again, you could use a generative AI for coding purposes. So technically, you could train it to code your physical examination, but for recording physical examination when using AI Scribe. What I recommend is actually, it's almost like pretending you're an OSCE, but one of the things patients find helpful anyways is when you're describing what you're doing, and as you're describing that to the patient and what you're finding is right afterwards, yes, the AI scribe will pick it up. It's actually fairly good. Sometimes it will, once again, for sports medicine terms, wasn't very good at picking up clavicle for some reason, kept referring to it as Pascals, but it can definitely record your physical examination if you speak it out. And what I recommend is you just describe the patient, the testing you're doing, and what the finding is afterwards.
I also had a question, Neil.
Yes.
Just the two questions so far have been on AI Scribe, but just another question was in your survey on the sports medicine physicians in the GTA, you had noticed that half didn't use AI. Did you have any sense on what the reasoning behind that was? Was it a lack of confidence in AI, awareness, perceived accessibility? What do you think it was?
Yeah, so I actually don't. We should do a follow-up with that. We can probably develop a better survey after today's talk. I suspect as I documented some of those initial things, everybody's probably using AI at this point, whether they know it or not. Um, and I think, it's only a matter of time. These things are embedded. I'll show an example of Zoom in the next slide. But like your Microsoft Suite now has Copilot in it. It's got the design slides option in it. Any of your Google Android products, your Apple products, there's an Apple language model, there's Google language models. These are ubiquitous. But specifically, it's kind of like ultrasound. Some of these things take time, like time to set up your AI Scribe account. And some people just don't take the time. They made a little bit longer. I think it's worthwhile taking a look at, especially if you're finding yourself under a time crunch. Some of these tools we talked about today can definitely improve your outcome. Somebody's asked here, any medical legal issues using Scribe and informed consent, is it more protective to the physician? You know what? These AI developments are happening so quick. This is part of the problem with the regulation. So I don't think it's any different from any other procedure that you want to consent the patient. We haven't come across anything yet from a medical legal, but I can only imagine it's going to occur. So are they going to pull the actual transcription pulled as opposed to just the note if something happens potentially? And how does that protect you? How does that protect the patient? Obviously, that's a direct recording. Um, there are variations in terms of like I said, even within errors within the transcription. But generally, I mean, it's kind of the equivalent I would say is in policing is perhaps a body cam in terms of it's giving you a live picture. Now, the if you turn it off, so it's not necessarily taking the entire encounter. So, for example, when you leave the room, perhaps to get something for an injection or get a prescription or a pamphlet or whatever, it's not going to record that. And sometimes there's extra bits of conversation. So this is another thing where, from a reflection piece that and a human oversight that you want to be making sure that gets put into the note. We talked about the privacy security concern. We talked about the transparency, being able to understand how these make decisions, these AI tools cost. So these are quite costly. Um, Anybody keeping up with the news, these are very highly energy dependent systems. They require a lot of processing power. One of the major steps forward before they had these new processing chips was they figured out a way to get to use the graphics card to do a lot of the processing for these AI developments. And um, as we'll see, it's one thing to talk about, for example, getting an image created is about the same as boiling a cup of water for your coffee. Um, if it's developing video or audio, that could be some of these could be the equivalent of like driving from here to Ottawa. These are fairly energy dependent processes, and you can see some of them will take quite a long time to develop. Now, I had a conversation last night with a colleague of mine. I just wanted to test the slides to make sure that the GIFs were working. Um, and I must have clicked something on the Zoom call, but I got an email right after the call. Giving me a summary of what we talked about, including I was joking about shoveling my friend's driveway when he was away, and it formulated that as part of our next steps of our academic planning, that now I have to shovel his driveway. Just really highlights the privacy concern, though. I wasn't really aware that this was doing this, nor was he. He's consented to this, but the whole idea here is that this now is being drawn up into a large language model. And so you really don't want to be discussing anything on these tools that you don't want to be talking about with others. You can summarize a presentation. Now, I just talked about how, from a regulation perspective, um, yeah, perfect, Mark. Yeah, I'm just wrapping up. This is the second last slide. This is the summary from within Microsoft PowerPoint Copilot. It gives me a summary of the talk that I hadn't even given at this point. And then this is another one down here on the left. This is Google's product. It's called Notebook LM. And I don't know if I can pull this up. I'm going to pull this up in a second. I'm going to show you an interesting thing. It will summarize a PowerPoint. You just save it as a PDF, feed it into the language model, and it'll spit out a summary. And it can do one other interesting thing. And hopefully I can show that at the end. So in summary, AI is already here. You can't really ignore it because your patients are using it, and they can check your answers to their questions with their AI tool. There are potential benefits, as we've seen, like just taking a look at the reduction in MRI time or documentation time with an AI scribe. But it's important to understand the process that it uses and the limitations. It's a tool. It's not a human replacement. Okay. Radiologists are still driving to work in non-autonomous vehicles. Okay. These tools require human supervision. I would like to thank everybody for joining me on this early morning. And if I could try just to show you the audio of this presentation that hadn't been presented. So this is a podcast based on this presentation. So let me close this out here. And can you guys hear this?
No, Neil.
Okay. I'm going to try one more thing. I'm going to take the headphones out. And let's try it this way.
All right, so today we're going to be taking a deep dive into AI in sports medicine.
Okay.
And this is all based on a presentation that you sent me called AI in Sports Med Citywide Rounds by Dr. Neil Dilworth.
Yes.
From February 18, 2025.
Right.
And one of the things that I thought was so cool about this presentation is that he actually used AI to help him generate the presentation itself.
Oh, yeah.
Like the images, the slides, and some of the demonstrations.
This was recorded by AI the day before the presentation has been given. But it just gives you an example of the power of its ability to summarize data. So from an education perspective and an education curation perspective, it has huge potential as well. Anybody has any other questions, feel free to reach out to me. Thank you very, very much for joining us. Thank you, Mark and David, for organizing, and looking forward to seeing everybody soon.
Thank you very much, Neil. That was an excellent talk. Are there any
Oh,
other
if there's any questions, yeah, sorry, I'll put the headphones back on.
It's a very timely topic, Neil. And that was Neil who was giving the talk, not Neil AI.
I didn't get around to that. That's the next one.
Right. Just a reminder to everyone again to please complete the survey to get your credits, and a reminder from Dr. Lawrence, the Cert Plus credits for the family physicians in the crowd. It can be found under University of Toronto citywide sport medicine rounds if you're trying to get credits for this. Great.